Good evening, everyone. It's my pleasure to welcome you to this evening's Thrombosis virtual rounds with a particular focus at addressing knowledge gaps in thrombosis. We're very excited to bring this session to you this evening. We have gathered together experts in the field from several disciplines, including experts in medical oncology, pharmacology, and as well as thrombosis experts or physicians who focus a lot of their clinical time thinking about these questions. Our aim tonight is really to have an informal discussion where you, the audience, brings questions or different types of scenarios to the table, and we have an open discussion about possible ways of addressing often these difficult scenarios that, there's no right or wrong way of addressing these, but through discussion we can come to some sort of understanding of what the challenges are and how we can go about dealing with these cases. You've had, some of you, the opportunity to send us some of your questions or scenarios, and hopefully we're going to be able to address these this evening in today's discussion. Before we get going, I'd like to take care of some housekeeping. So we do have a chat box, so I do welcome you to and invite you to post any questions or comments that you may have in the chat box, and we will be looking at that chat box and making sure that we can address your question or comments. And if we don't have time, we certainly will be able to get back to you at a later time. So without further ado, I'll start with some of the sort of housekeeping items that we will address, that I will address. So the steering committee for tonight's, for the virtual rounds are listed here. These include Dr. Jim Duquettes, who is on the session tonight and co-moderating with myself. Also, we have Jacob Iasso, Charlene Gill, Ryan Kersner, myself, Maria Marchesi, Stephanie Snow, and Stephanie Young. Some of the members are here with us tonight. That includes Dr. Charlene Gill and Stephanie Young as well, who is a pharmacist from St. John's, Newfoundland. If we move on, so the steering committee disclosures are listed here. I'll just pause for a minute for you to briefly look at these. And then we'll move on, I think, to the next slide. So tonight's panel includes myself, who I'm a general internal medicine specialist with a focus in thrombosis medicine from Montreal, Quebec, specifically at McGill University. Perhaps I'll give a moment for folks on the panel tonight to also sort of introduce themselves. So next, I welcome Dr. Jim Duquettes to give us a brief introduction.
Thank you very much, Vicki. Good evening, everyone. It's my pleasure to be part of this group again. I'm a general internist and thrombosis physician at McMaster, and delighted to be with you all tonight.
Dr. Gill?
Thank you, Vicki, and thank you to Thrombosis Canada for including me. I'm really looking forward to the discussion this evening. I'm a GI medical oncologist based out of BC Cancer in Vancouver.
And Stephanie Young.
Thanks, and as well, thanks to Thrombosis Canada for including me. I'm an associate professor at the School of Pharmacy here in St. John's. But I'm also a clinical pharmacist with our thrombosis service, our regional thrombosis service. So I currently run the DOAC clinic.
Great, thank you. So quite a varied group of experts in the field, and hopefully we'll be able to bring our different sort of experiences and to the table to be able to address some of these challenging topics tonight. So David, I'll move on to the next slide. So I do have to go through some disclosures, given that this session tonight is a Royal College accredited, Royal College of Physicians and Surgeons of Canada accredited event. So this program has received an educational grant from Pfizer Canada. And below you will see that there are potential conflicts of interest. The panel are eligible for honoraria from Thrombosis Canada, and Pfizer Canada benefits from the sale of a product that may be discussed in the program. Next, please. So I want to sort of highlight the following mitigating potential biases that may occur. So as with all Thrombosis Canada programs, the agenda and faculty have been developed by the Scientific Steering Committee, including members from Thrombosis Canada. All faculty will be directed that any recommendations involving clinical medicine are to be based on evidence that is accepted within our profession, and all scientific research referred to, reported, or used in this CME or CPD activity in support or justification of patient care recommendations conforms to generally accepted standards. Any mention of products must use the generic name, and speakers are asked to avoid making personal recommendations and to limit their presentation to a discussion of the evidence. Next slide, please. So this program meets the accreditation criteria as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada, and has been accredited by the Office of Continuing Professional Development of the Faculty of Medicine and Health Sciences, McGill University, for up to 1.5 Section 1 credits per hour. Next slide. So regarding the program tonight, these are the learning objectives. As mentioned earlier, our objectives are first and foremost is to try to address thrombosis practice challenges by engaging in discussions with a multidisciplinary panel of experts. Next is to describe the best practices in managing thrombosis after discussion with thrombosis experts, and to integrate as much as possible current evidence for specific patient populations into clinical practice after, reviewing these challenging cases with experts. And I just want to highlight that we have been forwarded some scenarios and challenging cases by the audience ahead of this session, but certainly through the chat box, we're very open to discussing some other potential cases that you may, as the audience, think of during this discussion. So without further ado, I think for the first half of this session tonight, I will be moderating the discussion. And then for the latter half, my co-chair, Dr. Jim Duquettes, will take over. So we will try to have a extremely engaging conversation. And without further ado, we'll begin with our first case scenario. Next slide. So here we have an audience member who asks the following question. We have a 68-year-old woman who was admitted with a pelvic fracture and deemed to be non-operative. Her past medical history includes hypertension, hypothyroidism, hyperlipidemia, peripheral artery disease, and coronary artery disease. And her current medications include, I guess specifically this audience member focuses in on the anti-thrombotics, and specifically with rivaroxaban 2.5 milligrams once a day and aspirin 81 milligrams once a day, as per the COMPASS trial. And so a pharmacist in the audience wondered and was consulted for how to manage thromboprophylaxis for this patient who has been admitted to the hospital with a significant pelvic fracture and has been deemed non-operative and potentially going to have quite a bit of time where her mobility is decreased. And so the question she was approached with was, is rivaroxaban 2.5 milligrams enough, meaning enough to prevent or help in prevention of thrombotic complications in the setting of a hospitalization, and what strategies we may suggest if rivaroxaban is not enough. And in fact, some of the strategies that are potential possibilities include stopping the rivaroxaban, continuing the aspirin, and initiating low molecular weight heparin until discharged and mobile. So I think there's a lot of things to tackle here. If we sort of step back and take a bird's eye view of this question, and it's certainly an extremely important question regarding thromboprophylaxis in hospitalized patients. And obviously that is a priority for our hospitalized patients. And I wonder, Stephanie, perhaps, how you engage and get involved in making decisions regarding thromboprophylaxis at your institution, for example.
Thanks, Vicki. This is certainly something I've been involved with a fair bit at our institution because, as you know, thromboprophylaxis is an accreditation standard. So how we chose to look at it in our institution is kind of a broad perspective. So looking at, what's the risk of the patients, and you can look at that in terms of there's a number of different risk scoring tools that you can use to help decide what the risk of a VTE in a hospitalized patients would be. So for example, in medical patients, a scoring tool like the PADRA score, or in surgery patients, the Caprini score. So we look at the risk of the patient and then do an assessment and then prescribe thromboprophylaxis based on that. And, certainly the majority of patients who come to the hospital are going to need thromboprophylaxis because they're going to be of sufficient risk. Mm-hmm. So when you look at the risk of patients, certainly orthopedic patients are at very high risk of VTE in terms of patients, for example, with elective hip and knee replacements and other orthopedic fractures. And certainly hip and knee, we know, are high risk. So looking at this patient in particular, we know they would be high risk for VTE, so would need thromboprophylaxis. So the only place really that the DOACs have been studied for thromboprophylaxis is in elective hip and knee replacements primarily. I mean, certainly there's some in medical patients, although that hasn't borne out as well as we would have liked. So primarily for orthopedic patients, the DOACs are really primarily for elective hip and knee replacement. Other patients such as hip fracture, or in this case, a pelvic fracture, most likely we would lean towards a low molecular weight heparin. Right. And even in terms of orthopedic dosing, the dose that was studied in the trials was 10 milligrams once a day. So certainly looking at this particular patient, the 2.5, I'm assuming it will be the 2.5 twice a day, which is what was studied in the COMPASS trial. But even that wouldn't be of sufficient dosing to meet thromboprophylaxis guidelines. So in a patient like this, certainly you'd want to look at the whole patient. You'd want to know, are there any other injuries or what their bleeding risk would be? Is there any role for mechanical thromboprophylaxis? But certainly, I think in a patient like this, I would see, stopping the rivaroxaban, potentially using low molecular weight heparin. So for example, a dose of enoxaparin, 40 milligrams once a day, perhaps. You could continue the aspirin, and you would need to continue the low molecular weight heparin until they're sufficiently mobile. I mean, some of the observational studies in pelvic fractures, go out to 30 days, but certainly it would depend on that individual case.
Right. It's and so you bring up at a very good point that these patients, certainly pelvic fracture and hip fractures, preventative strategies are primarily based on low molecular weight heparin strategies, given that the DOACs have not had rigorous study in this type of patient population. But I do wonder, in this kind of, when thinking about pelvic fractures, and often I come across some patients with, for example, malignancy and bone metastases, where, primary prevention with the DOAC. So I agree with you, in hospitalized patients, low molecular weight heparin has been well studied, but we do have some data regarding DOACs, at least, and perhaps not at a rivaroxaban 2.5 milligrams, but in cancer patients who are at risk for thrombosis, as we know, and in an outpatient setting, I wonder what the role of DOACs are in preventing thrombosis. So I was wondering, maybe Dr. Gill can speak to that a little bit.
Yeah, thank you, Vicky. I mean, I think, the burden of thrombosis and malignancy is huge. This case is interesting if you do think about it in the context of someone who presents with a fracture, and what if it was cancer, a malignancy-related fracture, a pathologic fracture, and sometimes that can be a presentation in patients with known disease. We think most commonly, breast, prostate, thyroid, lung, like those are the common, malignancies associated with bone metastases. And it can also be a presenting, symptom. My practice is GI, but I've had patients with liver cancer where their presentation was a pathologic, hip fracture. So, within that context, I think whether it's in a diagnosis or patients with known malignancy, I think then the question becomes, what is their thrombosis risk, not only in that perioperative sort of management of their fracture, but also sort of on a go-forward basis. I will say to you that, this is something we talk about a lot, primary prophylaxis. Mm-hmm. My primary area is GI malignancy. So, obviously, if you think about risk stratification using something like the Khorana risk score, gastric and pancreatic cancer is, high risk for malignancy. At the same time, those are the patients we are most, incentivized to want to offer primary prophylaxis because of the potential benefit, but also those are the patients where we worry about GI bleeding risk with DOACs. Mm-hmm. And so with each patient, honestly, it's a conversation trying to look at, what is that risk of bleeding? I lean in heavily with my hematology, internal medicine, pharmacy colleagues in making those decisions. It's hard to make a blanket statement, but I do think that becomes an issue. And then, if we're not able to use a DOAC and we're relying on low molecular weight heparin prophylaxis, there's a certain burden of that administration for patients on top of everything else that sometimes, is a factor for, adherence. Yeah. And so I'm not giving you a straightforward answer, but I think these are the kinds of things we think about in terms of trying to make a decision about primary prophylaxis.
Yeah, no, definitely. I think with the advent of both for apixaban and rivaroxaban lower dosing for primary prophylaxis in outpatient cancer patients that are deemed at high risk, and you've identified, for example, pancreatic cancer, for example, gastric cancer, we have data to suggest that certainly from an efficacy point of view, there is definitely a role for these agents in an outpatient setting. And certainly one must do that risk stratification of using, for example, the Khorana score and then determining what the bleeding risk is. Now, these trials did not incorporate a step 2 where they did an actual, risk stratification bleeding wise, but obviously there were many exclusion criteria. And certainly it may not be always generalizable to the patients that we're dealing with, for example, thrombocytopenias, renal failure. And so these are things that must be thought about. And moreover, like you said, reimbursement or how accessible these agents are. In some provinces, these agents, the DOACs, are not necessarily on provincial formularies with the proviso, with an indicator for funding for this type of indication. And in fact, that's maybe thinking about the usage of, antiplatelet and rivaroxaban, because this scenario does allude to the COMPASS trial. And for example, I wonder if folks on the panel are using this regimen in patients with peripheral arterial disease, because in talking right now with Charlene about the DOACs and on provincial formularies of the DOACs for certain indications, certainly in Quebec, we're just beginning to see acceptance of this combination for this indication. And I'm wondering, perhaps maybe, I don't know what the experience is. Jim, maybe you can let us know how your experience has been with this regimen for patients with peripheral arterial disease and the data that came out of COMPASS trial, and how things are in Ontario, for example, in reimbursing this combination.
Thank you, Vicki. Well, first of all, any kind of perspective for me is a bit skewed because the COMPASS trial, as you know, came out of PHRI at McMaster. Having said that, there is uptake and there is, at least Ontario, coverage, to my knowledge, for this regimen. But I think what we want to point out is that this is a regimen used for ambulatory patients with stable CAD or PAD. This scenario is very different. We've got a patient with a pelvic fracture, possibly pathological, which is a very high sort of venous thrombotic risk. So in regard to some of the questions, is Riva 2.5 milligrams enough? I think the short answer is probably no, because we only use 10 milligrams for prophylaxis in high-risk patients, knee or hip replacements, as Stephanie mentioned. And when you're dealing with the scenario where you've got a combination of an antiplatelet and an anticoagulant, you got to try to disentangle the two. I mean, we know that aspirin has thromboprophylactic properties, but we also know from the PEP trial that looked primarily at hip, not pelvic fractures, it also comes at a cost for increased bleeding. So I think the management here, and I agree with Stephanie, would be to try to get away from the DOAC and go either to a low molecular weight heparin, or you could use a pentasaccharide like fondaparinux, which has been studied specifically in hip fracture, and again, not pelvic fracture. And maybe, as for the ASA, I think that would need to be reassessed, but the default would be to continue. And just as an aside, I've been working with the COMPASS investigators to look at what happens to patients who not necessarily have pelvic fractures, but require elective surgery. And these are not published data, but the short answer is that there doesn't seem to be a lot of difference in terms of perioperative outcomes, whether you're using the 2.5, the 5, or just aspirin alone, probably because all of these regimens have antithrombotic efficacy. The point is that we're dealing with a high risk, very high risk situation. So I think the emphasis should be on preventing venous rather than just arterial disease.
Mm-hmm. And certainly these patients, obviously, as suggested by the scenario here, once the patient is discharged and mobile, can return back to their regimen that they were on beforehand. I wanted to see if there had any other questions in our chat box. We use the improve. So we have a question here, or a comment, I guess. We use the Improve IT score for medical patients. There seems to be some confusion as to what the thrombophilia risk factor means. In the study Improve IT, they use genetic thrombophilia, but I've read elsewhere that any inflammatory state could count as a thrombophilia. So I wonder, perhaps, Jim, what would you say to that comment?
Vicki, I think as the panel knows, there's two schools of thought about thromboprophylaxis in hospitalized medical patients. And the one is to use a selective approach, which is anchored on clinical prediction guides, like the Improve score, like the Padua score, and differentiate who gets prophylaxis and not. And the other approach is to sort of, if you're sick enough to come into the hospital these days, then you're sick enough to require prophylaxis. So rather than debate that, I think just to address the question, the Improve score is one. It's used widely in the United States, not so much in Europe. My experience is that it's not used widely in Canada. And to the question about what constitutes thrombophilia, well, we all know that inherited thrombophilias are quite rare. So you could probably include in there, people with cancer, but we know that that's a standalone major risk factor. In terms of inflammatory states, well, we know that COVID is becoming the prototypical example of inflammation leading to thrombosis. So, maybe that will be incorporated into the Improve score. But the short answer is, you can use these scores, but they also can be trumped by, clinical gestalt as well.
Yeah. So indeed, as pointed out by Jim, every institution uses, as actually first and foremost, Stephanie pointed out that it is an accreditation issue for every institution to have instilled and abide by a strategy for thromboprophylaxis for hospitalized patients, both medical and surgical patients. And definitely there are several scores that can be used both for thrombosis and bleeding. We do adopt a universal prophylaxis approach, and that is, one is a risk-based approach and the other one is a universal opt-out approach, at least for our surgical patients. And we find that works well with the buy-in of our pharmacy team, who assesses these patients, on a daily basis to ensure there are no sort of ensuing factors for bleeding, such as dropping platelets or whatnot, that would change the way we anticoagulate, how we provide the thromboprophylaxis to these to patients. But certainly, I agree with you, Jim. A pelvic fracture with several comorbidities, immobilized. This is a very prothrombotic individual, and one would have to ensure proper and evidence-based thromboprophylaxis regimen is instilled. So I think we'll move on to the next scenario, as I do not see any other comments or questions in the chat box. And if David could move on to the next scenario, that would be great. Okay. So a little bit, I guess, on the same sort of line with the antiplatelets, this audience member asks about the bleeding management for patients on antiplatelets and what to do if there's a need for an urgent surgery. Example, I assume these patients are on maybe it's not just for anticoagulant, but perhaps not just for an antiplatelet, but perhaps they're on an anticoagulant, and how one would manage these patients. So maybe what I'll do is, I'm wondering, Stephanie, do you have an approach when patients have bleeding problems, are in the hospitalized, and obviously stopping the antiplatelet in most of these cases is a straightforward decision, depending on the type or severity of bleeding. Any other supportive measures that can be taken for some of these patients?
So I'll say this is certainly not I'm more of an outpatient clinician as opposed to an inpatient. So we generally rely on our inpatient experts, but certainly, you know, when we've looked at bleeding management strategies as, you know, policies and guidelines for our institution, you know, certainly it would be consideration of things, you know, potentially like platelets, you know, and it does depend as well on which of the antiplatelet agents they have gotten, whether it's one of the P2Y12 inhibitors or whether it's aspirin, and even within the P2Y12 as to, you know, whether they got either clopidogrel, ticagrelor, or prasugrel. You know, with ticagrelor unfortunately being, you know, probably a little bit more challenging to manage. So I'll probably turn it over to the experts, inpatient physicians.
Yeah, so definitely. I think for sure the most important thing is in these patients, if there is significant major bleeding. So, and by major bleeding, obviously anything that causes hemodynamic compromise, anything that requires the patient to be hospitalized and requires blood transfusions, anything where there is bleeding in a critical organ, such as, you know, brain or GI tract. Definitely, you know, supportive measures have to be taken, whether it's volume and blood transfusion, to immediately ensure stability of that patient. And sometimes, you know, source control may entail using some of our colleagues to mitigate, you know, whether it's a GI bleed and the patient needs a gastroscope or a colonoscopy. Often we deal with this in our cancer patient population, and I'm sure Charlene can speak to this. And so for sure, definitely, that I think is the first step when dealing with these types of situations. Often also ancillary supportive measures may include, rarely though, the use of transfusion. I would say more often than not, platelet transfusions are not necessarily given in this type of scenario, because this, you know, aspirin is a binding agent and is an irreversible type of binding. So the effect of that aspirin is going to be there for a long period of time, and supplementing with acute platelet transfusion more often than not is not a strategy that we use. We find that tranexamic acid as well is in our armamentarium if needed for especially significant sometimes mucosal bleeding, gynae type bleeding. But I would say that most of the time mitigating, stopping the offending agent, providing supportive therapy such as volume and blood transfusion, and enlisting our colleagues for source control management through interventions often is the way we go with managing these patients. And one of the other things is sort of thinking down the road, does this patient need to be on an antiplatelet? You know, more often than not, I find myself in the business, and perhaps yourself, Stephanie, thinking about, you know, stopping indefinitely aspirin in many of these patients, especially with the latest data on, you know, primary prevention and really the non-use for this type of situation needs to be addressed as well. I wonder, Jim, if you have a different approach or take other types of considerations as well when dealing with somebody who's bleeding on an antiplatelet, for example.
No, not really, Vicki. There is no antidote, as we know, for any antiplatelet drug. There are technologies and drugs being developed actually in research that will actively remove antiplatelet drugs or either monoclonal antibodies or through mechanical methods. But right now, if somebody came into hospital and had a cranial bleed, was on dual antiplatelet therapy, we would be left with non-specific coagulation promoting agents like tranexamic acid. I think the question about dialysis is a bit, I don't think I've ever seen that being used. The only time that came up was with dabigatran, but even that was very rare. And as for transfusions, there was a trial recently looking at its role in patients with intracerebral hemorrhage and did not find any clinical benefit, not surprising because, as we know, these patients do uniformly poorly. So it's really just supportive care through non-specific coagulation promoting agents.
Yeah. And Charlene, I'm wondering, do you face quite a bit of this in your cancer patient population? I do know, I mean, often aspirin is actually used for primary prevention, but mostly in multiple myeloma patients rather than solid tumors. But certainly, I'm curious to know your experiences have been, especially with GI malignancies and the higher risk of GI bleeding in these individuals.
Yeah, I think maybe less so with antiplatelets, but well, we're on the subject of sort of bleeding, and anticoagulation. I think that's a major issue. Like we always think of bleeding, and we think of these scenarios of these acute kinds of, upper GI bleeds and things like that. But very commonly, patients with like luminal GI malignancies have like slow ooze type bleeding. It's not that they're presenting with an acute event. In those events, like you said, the decision is very clear. You stop the antiplatelet if they're on antiplatelet or anticoagulant. It's harder in patients who have, this chronic bleed from tumors. So we sometimes have to, we'll try our best to address the underlying, problem. So we use palliative radiotherapy for hemostasis for, inoperable primaries that are slowly kind of bleeding in that fashion. That often can help sort of control that, and then try to continue them on their anticoagulation for management of their malignancy-related thrombosis. We've had, so I think that is it's a very careful risk benefit analysis. I've had some patients, honestly, who have elected, let's say that, because we're talking about patients, many cases with advanced disease, and we have typically talked about anticoagulation for as long as they have active cancer until it's, reasonable or they're approaching end of life. I've had some patients who, after the first, 3 to 6 months, if they're kind of being readmitted for transfusion support, will elect to say, look, I'm going to come off my anticoagulation after 3 months and, after the acute event. And, we take our chances, because the burden of having to come in for a 4-hour transfusion every few weeks, even on an outpatient basis, is not good for their quality of life. So, again, these have to be kind of considered on a case-by-case basis, but it is a huge, issue for us in managing our patients with inoperable primaries who have these slow ongoing bleeds.
Yeah, no, definitely. And like you brought up an important point is sometimes when they have these bleeds and you stop the anticoagulant, the question always arises, when do you resume if you make that decision to resume? So, somebody's in the early 6 weeks in their 6th week of therapy for a DVT, a femoral DVT, for example, and they have a GI bleed, and they get their gastroscope and they find an ulcer, for example, and there may be hemostasis is achieved through some sort of intervention that the gastroenterologist proceeds with. But then the question always arises, mitigating that risk, when to resume that anticoagulant. And we do have data to suggest that these patients, when you resume their anticoagulant, their risk of thrombosis is decreased. But it's finding that timing where the risk of bleeding is not, increased further thereafter. And we often struggle with this in patients with intracranial hemorrhage. So, and in fact, many of these patients are patients with cancer who have, metastases, who may bleed, and then trying to determine post-CNS bleed when to resume anticoagulation is an important question. And in fact, I think is something that we struggle with quite a bit.
The intracranial bleeds from either primary or second, CNS tumors or secondary metastases is also something we struggle with. I think the other complicating factor is that, the use of certain types of anti-angiogenic oncologic therapies like bevacizumab are often indicated in, patients with GBMs and things like that. So if they're on that kind of concurrent therapy that may alter their risk of bleeding, that factors into the decision as well. But, usually we kind of think about, treated brain mets versus untreated brain mets in that risk assessment. And so, again, patients who have had, brain metastases, but have had them treated, whether with stereotactic or whole brain radiotherapy, we think that attenuates their risk of bleeding. If they haven't had a prior bleed, we feel comfortable considering, either anticoagulation or, anti-angiogenic therapies. And so that's kind of, those are some of the considerations there.
Right. I wonder, Jim, do you have any sort of how you approach a CNS bleed, in the sense a patient who's suffered an intracranial hemorrhage, and do you consider other factors in making that decision as to if you resume anticoagulation, and if you make that decision to resume, when? So Stephanie mentioned whether or not these are a primary versus metastases. The thinking is more of the highly aggressive GBMs may have a higher risk of thrombosis than perhaps metastatic disease, although there may be types of primary cancers with mets to brain that are more likely to bleed than others. I'm thinking about thyroid, for example, and melanoma, for example. But are there other factors you take into account when you're making that decision?
Of course, we consider, a holistic approach with other risk factors for bleeding. But I wonder if I can kind of cycle back to Charlene and just ask her, are there situations if somebody's got like a primary tumor, or more commonly, as internists, we see metastatic tumors. And as you pointed out, Vicki, there are certain tumors like melanoma or thyroid that have a greater propensity for bleeding, but those are pretty unusual. So Charlene, are there any scenarios, should we be worried at all about anticoagulating somebody with a metastasis or to the brain, or for somebody with a GBM who develops thrombosis?
I think it's the matter of, I think prophylaxis is different, because I think if the risk of bleeding in a patient with known intracranial metastases who does not have any established thrombosis, it would weigh against maybe primary prophylaxis, because I do think, in untreated metastases, we worry about the risk of bleeding. And again, those patients may be on bevacizumab-based therapy as their anti-cancer treatment. For treatment of active thrombosis, I think we typically will, unless they have any evidence of bleeding, I think we generally would recommend re-imaging to make sure that there isn't any spontaneous bleeding that we weren't, aware of. But in that case, we would, look at the greater risk, what's going to determine their prognosis in the short term. And if they need if they have a thrombosis that needs treatment, we would obviously favor treating that. It's difficult for different malignancies because it kind of ties in also to where they are in the trajectory of their disease. So if you have patients who have heavily pretreated disease and who have we have to have an honest discussion about prognosis expectations. And so in some cases, perhaps, if the risks of anticoagulation outweigh the benefit and their prognosis is generally guarded, it may not make sense either. So it's that context of where they are and their overall disease as well. But for people with relatively newly diagnosed disease where you're hopeful that they may get some palliative benefit from treatment, we would want to anticoagulate them.
Okay.
Yeah, and that's my feeling as well. And I appreciate, as you point out, it's a very nuanced kind of decision-making process. So, certainly to involve our oncology or, neurosurgical colleagues, whatever the situation, but not to skirt the question that Vicky asked me about anticoagulating post ICH. I think we all know that it is critically dependent on the type of bleed and the propensity for rebleeding. Somebody who has a subdural is very different from somebody who may have a primary GBM or who may have something like amyloid angiopathy. So to me, my approach is generally very conservative. So I try to wait, see what the clinical course of the bleed is, and consult with one or more specialists. I think that if you were to ask me and pin me down, like Jim, like when do you restart on average? On average, it's around 3 to 4 weeks. Yeah. And we've done that even with patients who have mechanical heart valves. We just put them on aspirin, but withhold anticoagulation for at least that period of time.
Yeah, definitely. And there's some prospective series coming out. I mean, there are observational studies who more and more are suggesting a 4 to 6 week wait, in fact, with more of the lobar bleeds where they're more likely to have a recurrence. So, kind of in line with what we do, but important, I guess, Stephanie, these patients definitely, even though they may have intracranial hemorrhage, how do you see their thromboprophylaxis? Because, if they're admitted to hospital, they still have, that risk of thrombosis, irrespective. Obviously there was a risk of bleeding, but how do you see prophylaxis in these patients? And do you feel comfortable, guiding your prophylaxis regimens vis-a-vis providing prophylaxis to these patients?
Yes, certainly. We'll work with our neurosurge colleagues, mm-hmm. and in terms of what the risk for that individual patient, and we build our protocols around, giving some flexibility in those early, couple of days, but ask for continual reassessment of, is it time? Can we get some pharmacologic? And generally in the interim, they'll use mechanical prophylaxis. So either the thromboembolic stockings or the pneumatic compression devices. Certainly we, ask them on a regular basis to try and reassess. Right. Usually it's within a couple of days. If everything is stable and there's no evidence of rebleeding. But it is a bit of a balancing act for each patient as well.
Yeah, no, definitely. So I think we got different perspectives on how we manage patients who are bleeding on an antiplatelet or on a anticoagulant, and moreover, thinking about resuming and how we would resume. There are different factors that come into play. Always, though, remembering that thromboprophylaxis needs to be considered in the different, with both non-pharmacologic and pharmacologic in these individuals, and that needs to be assessed on a daily basis in a multidisciplinary fashion. So with that, and I don't think there are any other questions in the chat, I think we'll move on to the next scenario, which I'm not sure we kind of addressed. If David, you can, okay, no. So this question has to do with how many clinicians do a follow-up VQ scan at the end of treatment of PE? So that's, I guess, an interesting question. And I guess the audience member wonders whether or not a scan, and the basis for the scan, I presume, would be to look for a resolution perhaps of that PE, to look for markers of risk for chronic thromboembolic pulmonary hypertension, for example. That may be a concern for this audience member. So I guess what I'll first ask Jim as a clinician on the panel, and then I can add to that. But then I think there are other questions we can think about that arise from this, and thinking about how long we treat some of these individuals, especially whether or not they have an underlying risk factor, and often cancer being one of the ones we think about, or in the case of patients with short-term risk factors like surgery, for example, and how we deal with that. But what do you think about that question, Jim, in the VQ scan?
Sure, it's a very good question. It comes up a lot. And my approach, and I think a lot others, is that we don't routinely do re-imaging of the lungs, whether it's a VQ scan or a CTPA after a patient has a pulmonary embolism. Now, you may say, well, Jim, you do it for patients who have venous thrombosis. And that's true. We do a follow-up ultrasound at the time we stop anticoagulation for DVT. This is a little different because you tend to not have as much residual disease present. Where you do it, as Vicky was alluding to, is in patients who you suspect have ongoing who have ongoing symptoms, whether shortness of breath, and you suspect they may have CTEPH, or chronic thromboembolic pulmonary hypertension, occurring in about 2 to 3% of patients. In that situation, your first test actually would be a ultrasound of the heart, and if you see any evidence of RV dysfunction, then you go to a VQ. But generally, I don't do this on a routine basis. And patients will ask me, well, Dr. D, like, how do you know my clot is gone? And I think the answer is that if they're improved clinically, that's your answer.
Yeah. No, definitely. I think we don't either do routine VQ scans or ventilation perfusion scans in our patients as follow-up, either for prognostication or sometimes I've heard folks say, a new baseline. Should the patient down the road have a recurrence, then having a sort of a map and looking at what the new baseline potentially is. But in general, we do not do follow-up VQ scans and base our treatment, as alluded to by Jim, on thinking about what the risk factors were, whether this was a provoked or an unprovoked thrombotic event, and how the patient is, and the symptomatology. But this question does bring to mind the routine use of CT scan, though, especially in cancer patients who are getting restaged, and this issue of finding these incidental PEs, and so we're using imaging here if for another reason. Often it's for perhaps patients for restaging, for example, is the common scenario, or sometimes patient comes in with abdominal pain and the CT scanner picks up the lower cuts and, tells us they did note some sort of filling defect. And so I wonder, Charlene, what your approach is. It's Friday afternoon. You get back a CT scan report saying that there's a PE here in a patient you sent to get the CT scan as a staging procedure. And what do?
Vicky, you've just described like almost every Friday. The incidental PEs always come in on Friday afternoon.
Yeah.
But you're right. The truth is that in my world, we do a lot of CT imaging, for surveillance and follow-up, or for patients with active disease, trying to monitor for response. So in that context, it is truly not uncommon for us to find, patients who aren't reporting any symptoms, and that's incidental finding. So obviously we treat them, we'll kind of have a conversation with like what is the burden of clot burden on the imaging? Is it subsegmental? But invariably all of these patients are going to get anticoagulated. So we bring them back in and start them on anticoagulation and make a decision about outpatient versus inpatient therapy based on sort of the usual, their clinical status and the reasonableness of outpatient therapy. But the majority of our patients are treated for their incidentally found thromboses as an outpatient. I was thinking a bit about this question about, doing follow-ups after, a VQ scan. So in my practice, we don't routinely, once a patient is on anticoagulation, we don't do a follow-up to see if their clot has resolved. But because some of our patients with advanced disease who are getting scans, like let's say every 3 to 4 months, we do follow the evolution of their clot. And to Jim's point, we typically will see, that their thrombosis has resolved. And patients will see their report and say, can I come off my anticoagulation now? And then we'll talk about the importance of their ongoing, risk in the setting of active malignancy. I think in the curative setting where patients have, completed active cancer treatment and have no evidence of disease, we do, if a patient has an evidence of thrombosis, how normally, we think about unprovoked first episode of thromboembolism. We don't run around looking for malignancy, but I think this is where the history, taking a history and physical exam, and if there's a history of prior malignancy, even if it's been treated, resected, to make sure that this isn't how they're manifesting recurrence, I think is important. So sometimes we will have patients who will be referred back to us with recurrence that was diagnosed because of, evidence of thrombosis 2 years after they had surgery for their early stage colorectal cancer.
Yes, no, definitely. I think I've had 1 or 2 scenarios like this past year where often the exact scenario you describe with recurrent thrombosis in a presumed cured individual, where obviously that really then puts up my antenna and think about working with my oncologist to relook at the patient and the likelihood that this could be a cancer recurrence. And then, so I agree both with you, Charlene. An incidental PE in a cancer patient has a high risk of recurrence, and there is data to support that. And so treating these patients is exactly what one should do. Obviously, going through the whole risk benefits and discussion and looking at bleeding risk and so on. But there is data also to suggest that sometimes we think they're incidental, but some symptoms like non-traditional type of PE symptoms, such as overwhelming fatigue, or there was a study that looked at some of these atypical symptoms that found an association with incidental PE. So often going back and asking the question, what were you like? What were you feeling like in the past few weeks? You may find some symptoms that were not entirely, explainable away by their underlying cancer. And so one of the ones I hear about a lot is this profound fatigue. So sometimes it's not so incidental.
And it's a challenge because, the majority of our patients on chemo are fatigued, right? And so the sensitivity of that is hard, but you're right. You use your retrospectoscope or however you look back and say, well, that's probably what it was. I agree. Keeping vigilant about this is really important.
Right. It made me think a little bit and thinking about, and so we get a lot of these, and then you put them on, a direct oral anticoagulant. More often than not, you get the call on Friday. generally speaking, you call and the patient sounds well and has not been really short of breath. And more often than not, you can prescribe them, and you know them well. You had seen them a couple of days before, and you prescribe them that direct oral anticoagulant, whether it's apixaban or rivaroxaban. And my experience is I usually call my pharmacist to look at that list of medications that patient is taking, because there are, important interactions that we hear about and we need to be aware of with the direct oral anticoagulants and some of the oncologic therapies that are given. Now, wondering, Stephanie, what is your experience and your practice and your approach to a cancer patient who's being started on a direct oral anticoagulant?
Well, we'll look at things like the, all the bleeding risk factors. We'll go through all of their other medications to see if there's any interacting medications. And the challenge with the drug interactions is that there's some that we have good evidence for that it's an interaction, and others, and in particularly some of the newer targeted therapies or chemotherapy agents, we have to kind of look a little bit more at the drug itself and look at the kinetics of the drug. And it's almost like a theoretical, what would we predict would happen based on how that drug acts. So we try and look at all of those factors. And most patients will want to be on a DOAC because they're not keen, to do the injections. But, certainly if there's a significant interacting medication that can't be changed or stopped, then we have to, look at what the best alternative for the patient is. So we try to make sure we take all of the factors into consideration and, bring the patient into it as well in terms of, making sure that they understand and are in agreement with what the recommended therapy is. Okay.
Jim, do you do things differently in your practice?
I tend to be a little bit all-encompassing in terms of the treatments that I prescribe. So I still think there's a role for low molecular weight heparins, and in fact, I just wanted to segue a little bit because we got one of our audience members sent in a question about the issue of GI bleeding risk in patients who are receiving a DOAC as compared to a low molecular weight heparin, and whether the results of the apixaban versus dalteparin trial, which appeared to show no significant difference in GI bleeding, influences in our decision making, and if so, is there something about apixaban that is different than other DOACs? So I think this is a great question that raises a number of different issues. So, but to go back to your question, Vicky, I tend to be a little bit more cautious about using DOACs in patients with GI or GU malignancies or other patients at high bleed risk. And what I've tended to do is maybe start them on a low molecular weight heparin, and if I think they're going to require maintenance therapy and they're not bleeding, then I can switch them to a DOAC. We've got a number of choices, and it's great to have choices, but maybe I can put it back to Stephanie and Charlene about their approach in patients who have GI or GU malignancies. I mean, how convinced are you with some of these randomized trial data? And do you think that apixaban is different than the other DOACs? I don't know, Stephanie, do you want to have a crack at that? It's a tough one, I know.
And certainly we'll work with the oncology team in terms of what is the, what specific GI malignancy do they have, or GU malignancy, has it been resected or not, kind of what the stage is. Certainly there is concern, and there does seem to be, some concern with edoxaban and rivaroxaban with regard to bleeding with the GI malignancies. We seem to have at our clinic a little bit more of a comfort, I think, with apixaban, because when you look not only in the cancer trials, but across the other trials, apixaban seems to have, less bleeding. Is that something to do with the specific, pharmacokinetic or pharmacodynamic effect or, structure of the drug? I'm not entirely sure, but in terms of clinical outcomes that we see, but, certainly it's a decision if there's any other bleeding risk factors or, they may be at higher risk based on what we hear from their oncologist about bleeding risk, then we may err towards the low molecular weight heparin. We try not to use warfarin if we can get away with it.
Right. And Charlene, what is your
I was just gonna say that back to the scenario of the Friday afternoon call. Potential PE. So in my practice, I actually will start everyone on a low molecular weight heparin, recognizing I treat only GI cancer. So my initial approach is to start them on low molecular heparin. I practice in an environment where I have the benefit of being able to refer my patients with cancer with thrombosis to a thrombosis clinic. We have a clinic in our hospital run by Aggie Lee, who and so these patients, it was trajectory changing in my practice when this clinic was started many years ago, because that really affords them an opportunity to be connected with a thrombosis specialist. And typically that discussion about a switch to a DOAC happens with the hematologist. Now, I realize that's not the practice environment for a lot of people, but I think that I lean again heavily on their expertise. In my practice, I do see a lot of patients when they do come back more commonly on apixaban. But as a very simple medical oncologist, I currently start everyone on low molecular weight heparin until someone who knows better than me can make that decision with the patient. And the other thing is the discussion you mentioned about interactions. So, we always think about sort of the usual P-glycoprotein, CYP3A4 types of interactions. And increasingly, with more and more sort of therapies like these tyrosine kinase inhibitors that are a big part of sort of targeted therapies, I think that also becomes more of an issue. And so again, relying on our pharmacists, our oncology pharmacists to kind of help sort out, which ones are material interactions, which ones or not. I think, I think it circles back to how we need really a team-based approach in managing these patients well.
Yeah, no, definitely. And I think I can agree with everyone. It's not uncommon for me to use a low molecular weight heparin and a DOAC in a cancer patient throughout the continuum of their care. Certainly, I can think of scenarios where I will start off with a low molecular weight heparin where I am concerned about a GI bleed or even a GU bleed. And often I have experience using a low molecular weight heparin in those types of scenarios where I can actually, not that I do it, it will depend on the type of thrombotic event I'm dealing with and other prothrombotic factors, but I can mitigate with my dosing how I go about controlling if there is bleeding. So, hematuria may not be so significant per se in a GU malignancy where, you are able to continue with your low molecular weight heparin and perhaps we can decrease the dose for a brief period of time and then think about going on to a DOAC. And also in patients with massive PEs or massive femoral DVTs, I'm much more comfortable using low molecular weight heparin just because of experience and having that fortitude of knowing how to use that medication in that type of scenario.
I just wanted to add to that, one of the challenges that we face, and I think this varies across the country, but our public plan for coverage doesn't cover low molecular weight heparin.
Okay.
Beyond, a 7 to 10 day period. So we're often having to, now we do take advantage of other programs that are available to try, and if we feel a low molecular weight heparin is the most appropriate to try and get that for the patient. But I think, certainly there are variations in terms of access.
For sure. And that's another confounding factor to consider, definitely. Great. So I think we'll move on. I think we have one more scenario. So we have about 20 minutes or so left. So let's move on, I think, David, to our next one. Yeah, this is the one. So here we have upper extremity DVT. And so this happens to be a non-catheter related upper extremity DVT. And so the first question here is how one would work up, what workup should be done for these individuals who present with an upper extremity DVT. So I would say that probably of all the upper extremity DVTs that present, it's more of the less prevalent cases that do not have a catheter implicated. I would say, in 75% of these cases of upper extremity DVT, we're dealing with a catheter-associated thrombosis. So certainly it's not as common, but definitely what kind of workup one would do is important to consider. I wonder, perhaps maybe I'll go with Jim on this one. What would be the first thing you're thinking about when somebody's presenting with a non-catheter upper extremity DVT?
Well, the first question I would ask is how often are they in the gym? Are they serious bodybuilders? We're familiar with Osgood-Schlatter syndrome, which is, I think, extrinsic compression of the thoracic outlet venous structures in the axillary area. And of course, there may be superimposed muscular abnormalities. But the other situation is that, in the absence of that, you'd be concerned about some type of primary malignancy as well. Most of these are catheter associated, as you say, Vicky. So I routinely do either an MR or CT of the neck and chest to look for any, thoracic outlet obstruction. And, the other scenario is typically young males that are, very bulky, and, there's not too much you can do about that. The only other thing I would add is, things like how long to anticoagulate. It's very patient specific. First rib resection, I'm not really going to go there. I'd have to involve a thoracic surgeon. But mainly, the point about the ovarian pathology and this theoretical effect of, spread of the tumor through the vein into the IVC, and whether it causes an upper extremity DVT. In over 30 years of practice, I haven't seen one case, for what that's worth. But I think the short answer is look for secondary causes, definitely, whether it's acquired or, and if you can't, then there are rare circumstances of inherited, thoracic outlet syndromes where a surgical intervention may be warranted.
Yeah. So, so this would be an atypical clot. And so we get ourselves in the mindset of thinking about an atypical clot. And Jim has alluded to the common sort of thinking about, thoracic outlet syndrome. I should say, I also work closely. You should also consider working closely with your, when you're considering a thoracic outlet syndrome, with vascular surgeons, and thinking about specifically sometimes they've pointed out to me that often when they're asking for a CT scanner, they end up repeating the CT scan that I may be, or somebody's ordering in the emergency room when this young person comes in, because you should ask with a movement where the patient gets a CT scan with the arm hyperextended above and below, so that they can look at the different angles that are possible and can contribute to thoracic outlet. So that's always an interesting sort of thing to think about. Yeah, and so if you do find that there is sort of an anatomical reasoning for this upper extremity DVT, then obviously referring to vascular surgery or thoracic surgery for resection or whatnot is necessary. Then I do think there are some questions in the chat box that may be related to this scenario or not. So because we have about 10 minutes left, I'd like to go to the questions unless there are any other added comments to this scenario. I think, Charlene, your experience with this is mostly with catheter-related thrombosis, and we clearly treat these patients with anticoagulants and trying to preserve the catheter as much as possible because it is a vital to the treatment that these patients are receiving. So maybe I'll just quickly go through the questions. So the first question we have is, I'd love to get the panel's opinion on the fact that apixaban had similar rates of GI bleeding compared to dalteparin and Caravaggio. So sort of going back to what we were discussing earlier, whereas with the other DOACs, there was more bleeding in the GI malignancies in their respective trials. Any thoughts on why apixaban is different than the others? So I guess we kind of alluded to this earlier, and Stephanie spoke about, this issue. And I think, as the panel mentioned, it's not clear why this was seen with apixaban. Obviously, the first question folks may wonder about is patient selection. When looking at the various trials of the edoxaban trial, the rivaroxaban trial, and the apixaban trial, although there were some differences, mostly having to do, for example, in the apixaban trial, there were no CNS or primary CNS malignancies enrolled in this cohort of patients in this trial population. It doesn't really allude to this issue with the GI malignancy bleeding that was that this attendee or audience member is alluding to. And sort of like Stephanie mentioned, it may be that there is something about apixaban, given that we're seeing a consistent sort of less bleeding risk in AFib trials, for example, where we're seeing that consistency across those types of patient populations as well. And so it remains to be seen. Apixaban is the latecomer in the cancer trials thus far. But certainly I am seeing an uptake on this medication in cancer patients for their treatment of a DVTP, and presumably there may be this observation that's driving some of that. Any other comments from the panel? Or I think we did address most of it in the last scenario, but if there are any, before I move on to the next question. Okay. Oh, yes, Jim, sorry.
The only thing I would add here is that when you see this type of result, and that is drug and not class specific, you have to be a bit skeptical. And it's not to say that it doesn't occur, but we don't have very many head-to-head. In fact, we don't have any head-to-head DOAC trials. And I know there are some that are ongoing. Dr. Castellucci is doing the Cobra trial, comparing apixaban to rivaroxaban, looking if it causes less bleeding. So I think we have to have a fair share of skepticism. Does a single dose matter versus splitting the dose? Could that have an effect? I mean, Stephanie, you might want to weigh in on that, but I just would be a little bit conservative in terms of interpreting kind of subgroup analyses, especially when there are, no head-to-head DOAC trials.
Yeah. Stephanie, did you have anything further to add, or?
No, certainly I'd agree with that. And I think it will be very interesting and welcome to see the trials that do directly compare them, because mostly what we have is either, indirect comparison or observational studies.
Right. And I do have to say that, one of the things I fear down the road is, well, obviously depending on provincial formulary sort of programs and reimbursement programs, what I am seeing, at least in my province, is that our provincial formulary has funding reimbursement for the apixaban 2.5 dose for secondary prevention after 6 months of full dose, 5 milligrams twice a day for treatment of thrombosis. And so my fear or my issue is that changing a cancer patient to a 2.5 dose at 6 months may be a sort of a thing that, something that may start to be done as a result of people of taking on, apixaban more so than the other DOACs, perhaps based on the Caravaggio study, and thinking about using the 2.5 after 6 months, knowing full well that the 2.5 milligram dose was compared to placebo for secondary prevention in patients where physicians felt that there was, equipoise in then randomizing somebody to placebo versus 2.5, and cancer patients were not included in that study. And so I would hope that one of the flags here is not to consider that a cancer patient is equivalent to a non-cancer patient when thinking about secondary prevention down the road. And then our other comment here in the last few minutes, question has to do with, do you usually stick with low molecular weight heparin in a patient with cancer-associated thrombosis who has had a gastrectomy? And that's a super important question, definitely, having to do with, oral absorption of the DOAC. So I wonder, Stephanie, what are your thoughts on that? Can we ever use a DOAC in these patients?
So I think you'd have to look at, specifically what was the surgery that was done and what was resected, because we know there are differences with regard to absorption of the DOACs in the GI tract. And for example, rivaroxaban having mostly absorption in the stomach and the initial small bowel versus, apixaban and edoxaban. Apixaban is, having absorption kind of beyond the stomach, and edoxaban and dabigatran as well, but we don't use dabigatran a whole lot. But certainly of the ones that we frequently use, you just have to look at where they're absorbed along the GI tract. So potentially, depending on what is left of the GI tract, I think that'll help decide whether or not you may be able to use one of the DOACs.
Okay. I know, Jim, you work at a bariatric center, I think. What do you usually do? Bariatric surgery center, sorry.
Yes, that's a whole question in of itself, Vicky. The default for people that are not sure is to stick with warfarin. We kind of downgraded a bit from it, and it's justifiably so in patients with cancer. But if you're not sure, it's your go-to drug. So that's what we still use as our first line. And there have been some preliminary case series that suggest that DOACs are safe and they are, absorbed. And I think Stephanie's point is well taken, that the apixaban has a sort of broader kind of area for absorption, so there's some considerations that would favor that. But I think the message, for the audience is, if you're not sure, just stick with warfarin, and in some cases maybe even a low molecular heparin.
Yeah,
and I think as well it depends on what. I can't remember what the question is, if it was in terms of treatment versus prophylaxis, because I think that makes a difference as well, with regard to, what agent you may use. I know in our bariatric patients for prophylaxis, we may err towards particularly in the early days with the low molecular weight heparin, because you are unsure of what the, any absorption is going to be like. And, similarly, if you're looking at treating a new VTE event, you may elect to use a low molecular weight heparin in the early stages in that first, 4 to 6 weeks.
Yeah, no, I agree. Messages that if you're not, you cannot depend on reliability of your absorption of these medications early on. And definitely, I'm a proponent of using low molecular weight heparin initially. So like Charlene says, she starts everybody on low molecular weight heparin, and then they can be switched off later on to a direct oral anticoagulant. But that is certainly, I usually begin with low molecular weight heparin as well. So I think we missed one question, and that will be it. Because I do want to be able to address everyone's question tonight. The question perhaps has to go back to our catheter-associated thrombosis. And the question says, when would you consider early thrombolysis for upper extremity DVT? So maybe, I think for sure that is an interesting question. There are no guidelines per se that definitively tell you to thrombolyse these individuals. Maybe Jim, do you have any experience in this area and can shed some light on this?
Well, thrombolysis may be considered if you're a professional athlete named Steven Stamkos, who actually got this after he got a clot in his arm, and it was out for a few weeks before he won 2 Stanley Cups, that is.
Yeah.
So the answer is you have to be highly selective.
Yeah.
Having said that, there are patients that have post-thrombotic syndrome, and these are often the young, weightlifters that I alluded to earlier. And if there's a persisting mechanical obstruction, but then you may want to consider, long-term surgical options. But maybe I could sort of segue and ask Charlene, like what her experience has been in general with catheter. I mean, you see a lot of patients with Hickmans and portacaths. Do they seem to do well in terms of the viability of the catheter? Have you had situations where you've had to take the catheter out, or even, use a little bit of TPA like we use in the dialysis population?
Yeah, I think that, I silenced my phone, but then my watch started ringing. I'll start off by saying that I use catheters a lot, primarily port and it's still a relatively uncommon scenario for us to have catheter-related thromboses, even in patients who aren't already on some prophylaxis. So thankfully, it's actually not something that I see as commonly. In those cases where I do see it, to Vicky's point earlier, we do our best to try to salvage the port and start them on anticoagulation. Sometimes it depends on the extent of the clot and the associated presentation. But typically, I find that the intraluminal patency of the catheter, in terms of being able to continue to use it, is not affected in a way that that's usually not the limiting factor. So I would say I can think of, in the last 5 years, one case where a port was removed because of a complication of thrombosis, and usually we are able to salvage it.
Yeah. Great. I think it's 8:30. I want to really thank the audience for their very interesting and challenging cases. It's just a flavor of what we deal with every day. I always say thrombosis is often not black and white, and there are many gray areas there. And I think I want to thank Stephanie, Jim, and Charlene in engaging with me tonight and with the audience in trying to address some of these difficult scenarios. I would also want to thank David for the support that he gave us tonight in setting up this program, as well as Pfizer for their support in Thrombosis Canada and helping support these important rounds. And I want to just say that to the audience to please complete the evaluation for our accreditation purposes. at a link that I believe David has provided in the chat box, and potentially maybe emailing to you, but certainly that link is there in the chat box. So I really want to thank everyone for this Thursday evening discussion. Very interesting. There are 2 more, I think, sessions planned over the next couple of months till the end of November. The dates will be announced or have been announced, but I don't have them off the top of my head right now. But anyway, thank you, everyone. Have a good evening, and till next time.
Good evening, everyone.
Thank you so much. Good evening.
Thank you, everybody.